Well, it's my pleasure to, just a few minutes late, welcome Dr. Jason Perepelkin, to the University of Wisconsin-Madison. Dr. Perepelkin is an associate professor in the College of Pharmacy and Nutrition at the University of Saskatchewan. He's also an associate member of the Edwards School of Business in the Department of Management and Marketing. He has research interests in, no surprises here, burnout and work engagement, but also in a number of other areas, including patient experiences with IV ketamine, which I'll speak about tomorrow, as well as pharmacy owner succession planning, patient-reported experience measures, organizational theory and behavior, and that's just a flavor of some of his research interests. I'll point you very quickly to two of his recent publications. First, Prescription for Change, Unveiling Burnout Perspectives Among Pharmacy Leaders, which was published this year. That was in Canadian Pharmacist Journal. And then secondly, the mediating role of burnout in the anxiety and work engagement relationship. And that is in the Journal of Health Management. And it's a pleasure to have you here, not just for one talk, but another talk tomorrow as well. So I'll turn it over to you.
Thank you. Yeah, so thank you for this opportunity. I'm sorry that I maybe something to do with my using Apple and then it doesn't want to play nicely or something, but and now all of a sudden I can't see. Oh, there we go. There. So maybe not everyone knows where Luke came from, because it ends up that he came from the same place as me. And we didn't figure that out, or I didn't meet Luke until what was it, July, and at the International Social Pharmacy Workshop. And he told me about his drive to Saskatoon before. So I want to start kind of with where did I come from in Saskatchewan? Some people might have trouble with that word. So it's about 1,200-mile drive. I've done it twice. The most recent was in 2019 for AIHP in Chicago. And we drove because my 5-year-old wanted to go to Noah's Ark Water Park. But then it was a big mistake because about 10 minutes outside the city, he's like, "Where are we there yet?" And so it was something else. And so today I drove though. Or flew, sorry. Yeah. Yeah, I didn't
took about
drive.
18 hours.
Yeah. Oh, yeah. My luggage took 18 hours to get here. 18 extra hours, so. Yeah, and so just so you know kind of where I'm coming from, the province is about 1.2 million people, mostly in the the southern quarter of the province is where most of it. Up north is a lot just mining and a lot of wonderful lakes, but forested like crazy. And in Saskatoon, where the university is located, there's about 375,000 people, and then some surrounding communities as well. Our university as a whole is founded in 1907. I know that our former dean did his schooling in Texas, and so people say, "Oh, that's a brand new school," because there's been so many schools here pop up, and he's like, "Nope, we've been around since 1907." So I just want to throw that in. And so our college started in 1914, and then now we took on nutrition about 30 years ago now, but they were kind of by themselves, and so it's too small of a college. So it's a little bit unique, set up that way, and we have all health sciences and such too there. So today I'm just going to go over a high level overview of kind of burnout, some work engagement and occupational recovery, and then look at two studies that I've completed that Luke mentioned, the 2 papers, and then 2 that I've completed the data collection, but not the actual and that full analysis yet, but the kind of preliminary things there. So so there's growing evidence that there needs to be some evidence-based interventions for burnout, because what's being done or talked about isn't doing much for workers of all kinds, not just healthcare professionals, not just pharmacists. And when you look at burnout itself, if you want to look at strictly as a financial thing, There's that reduced productivity, includes increased job turnover. When you get that, obviously it costs money to train new people. Medical errors, poor patient satisfaction, especially when you're in a, you know, you want people to keep coming back and repeat. And for, obviously for financial reasons, but also for better patient care, is that if they keep coming back and you have that relationship with them, it's better. The common sentiment is that there should be personal, organizational, and systematic solutions. And in the past, it's been heavily focused on the personal, like individuals should be doing things differently. So the concept of burnout was first described by Freudenberger. He, a psychologist, German born but American, and he described burnout. So it was at that point 2 words. And I kind of thought about this morning when I was putting some last things together, that it's kind of like when email first came out, there was an e-mail and it's kind of just merged. So burnout's merged into 1 word now. But he felt it was a state of mental and physical exhaustion because of one's professions and the responsibilities, and especially those in the caring professions. It's rooted in unbalanced maladaptive relationship between individuals and their work. And we'll look a little bit more about that. It's a response to chronic workplace stressors. And there's some argument too that it says that it's about workplace stress and what happens at work leads to it, but you can't, I mean, aren't siloed completely. So when you go home, you bring work home with you and you bring your family life to work as well. So I don't think that it can be completely separate. The most common definition or description of burnout recognized is a syndrome that has emotional exhaustion, depersonalization, or cynicism is what it's looked at with the health or the caring professions. And then reduced personal accomplishment or inefficacy in one's job. And so the most common method to measure burnout has been since 81 has been the Maslach burnout inventory. And so it looks at those 3. So the emotional exhaustion are a physical and emotional response to those overextended work demands. The depersonalization of cynicism is when people start having a negative or callous relationship to work and they're more detached. And obviously, if you're supposed to be in a caring, or you are in a caring profession, being detached from your patients, and that isn't a good sign. And then the personal accomplishment or inefficacy is feelings of incompetence and unproductivity, that you can't do what you expect that you should be doing or should be able to do. And in some cases is what you were able to do in the past. So some potential causes of burnout in pharmacy itself have been shown to be heavy or high workloads. And I think that we see that not just in Canada. I follow closely what's going on here in the States, and there's a lot around heavy workload, and with pharmacies closing down and then new patients coming to your pharmacy, and you still expect to take care of the other ones. So there's industry changes and consolidations. We see pharmacy deserts in a lot of places, that constant need for precision and urgency in tasks. And so like I kind of tell my students, so I do leadership and management type of teaching, and I say that, you know, if I do a presentation or a talk and I mess up, I'm okay, because there's no chance of anyone dying because of it. But when they're in their job, that there's a chance that if they mess up, that someone could be injured or die from it. Insufficient staffing is that, and doesn't necessarily mean that the bodies aren't there, it's just not the right type of bodies. So you may need either like pharmacists or registered technicians, and you have an assistant instead. Inefficient work processes. So a lot of the models of pharmacy, even though it's going more and more clinical, the model's still around that dispensing tasks. And so that transactional model that doesn't really work into the cognitive part of services. Performance metrics, they have a place to play, but they get in the way a lot with that. And you're seeing it not just in community pharmacy, but you're seeing it in hospitals and healthcare systems as well. The lack of autonomy being taken away, so what you're supposed to do, and precedence sometimes takes on, you know, towing the company line and saying their script. Time constraints, management issues, especially if there's non-pharmacists being involved in telling you what to do. Inadequate work-life balance, and then moral distress around you can't help everyone that needs your help, and so you're left with that weight on your shoulders. One model that kind of looks at how can you look at the causes and maybe the ways that we can overcome burnout or at least recover from it. Would be job demands resource model, and so it looks at that each occupation has physical, psychological, social, and organizational demands, and the application of those skills and effort results in the personal cost to the worker. And that's what you're being paid for, is your personal cost, but at what point does it tip over to be detrimental? And so you can see in the model that the demands are the mental, emotional, and physical, but the resources aren't just physical resources, they're that support. So yes, support could be more staff, but it also could be the feedback, it could be you know, just a pat on the shoulder, autonomy to do your job, so what you're trained to do, if it's coming up against what your code of ethics is. So this physiological and psychological costs create stress and predispose a worker to burnout in this model. And then functionally job resources moderate the negative effects of one's professional fulfillment. And so in pharmacy, it appears resources are inadequate, and that's, you know, in many jurisdictions. So Canada, US, the UK, I follow quite closely, in Australia as well, that there's a lot of this going on as well. So, and it doesn't really matter what the ownership model is. So if it's pharmacist owned or corporate owned, there seems to be the same issues. And that pharmacists lack awareness of their availability with the resources out there too. And some of that was highlighted in our research that I'll look at. So some demands in pharmacy are the high workload that I mentioned earlier. So you're often faced with higher workloads. And I've watched quite a few things and read quite a bit from especially Ohio and what's going on there, and their regulator is doing a lot of good things, but people are waiting a month to get a prescription refilled, which is absolutely ridiculous to me, but you can only do so much. And so that's where you have that moral distress as well. The emotional demands is that you deal with patients that are in distress themselves or don't understand what their complex medical needs are, and then it's emotionally taxing on you. And then the time pressure. So doesn't seem to be enough time. It's that, and then in pharmacy, you're also having to be reactive too, because if you're in a community pharmacy, someone can show up. And so it's touted as pharmacy is the most accessible profession, but there's negatives to that too, because everyone thinks that they can just ask you anything and take your time whenever. And so we know that errors go up too when you get interrupted from doing a task. Potential resources are a supportive work environment. So even if the work environment is, the physical environment is not great and you're in high demands, if you have supportive work environment and colleagues, that helps quite a bit. So you feel that whole misery loves company is true in this case, and that people, if you're in it together and you're helping each other out and you're doing what you can, that's supportive a lot. I'll throw in some personal things, but when I was in high school, I actually worked at a 7-Eleven, and people laugh and think that's funny, but it was actually one of the best jobs I had because the supportive environment, like we had fun. We glued coins to the floor and watched people try to pick them up and stuff. So that was, and I still very good friends with some of these people now. So if you have a supportive work environment, you can make anything work. And not saying that 7-Eleven is the same as pharmacy, but you could have fun too. The autonomy. So the more autonomy you have in things, so if you have control over your work schedule, which we know a lot of pharmacists don't, but if you at least have some input in what you're able to do, we know that in a supportive work environment, some managers will schedule themselves on weekends as well, not just their staff. And also the decision-making process, that pharmacists are taught to question things and, look at the evidence, and then you're also being told to do something without input on that. And so why would they not resist? And then professional development. So yes, all pharmacists require continuing education, but can you focus on what you want? Because there's some corporations that say we'll only pay you to do ours, and they very much control what's being done. And then another aspect in this whole burnout realm is looking at work engagement. So it's described as positive, fulfilling, satisfying work related. So it looks at vigor, which is high levels of energy and mental resilience. that people bring to their work, and so. You know, you're doing stuff that you want to do, and so you're energized to do that. Dedication is characterized as strong involvement in one's work, and so sense of significance, enthusiasm, and pride, or I don't know if I can say pride now, so and then absorption, that you're fully concentrated and happily engrossed in your work. And so that time seems to pass quickly. So if you're doing things that you love to do and you're able to control that environment, even if there are things that come along that may throw you off, if you're absorbed in your work, then that's going to help quite a bit to prevent it and starve off burnout. The greater employee engagement, the more likely they are to be working at peak performance, their productivity is enhanced, and objectively financial returns for the organization. And so some people argue that, well, we don't want pharmacy is supposed to be, it's a healthcare profession, but trying to ignore the financial aspects is not going to work, because even if you're not about that, if your pharmacy fails to make money, it's going to fail to stay open. And then what good are you doing to the community that way? And so especially when we see these pharmacy deserts in some locations. And engagement and burnout are negatively related concepts. And so engagement's posed as an antipod and potential antidote to burnout. And so emotional exhaustion, depersonalization, or cynicism is the opposite of vigor and dedication and work engagement. So some things that are being done to combat burnout are workshops and programs that look at stress management, mindfulness, resilience, meditation, communication skills too. So how can you ask for what you want? With that also comes a sense of psychological safety, that you can ask for things in the right environment, and that you don't feel that you're going to be judged for that and potentially lose your job. Looking at self-care, and not self-care as in looking over the counter stuff, but self-care for yourself. But relying just on personal approaches appears to be insufficient and even harmful to employees, because it's looking at blaming them for the issue and not necessarily the environment that they're in and the system. And so some people say, well, why does one person feel more burnt out than the other? But there's a lot of factors that come into play, but blaming someone is not going to work. So we know that it's involves three aspects. So the organizational, the individual, and then outside sources. So the systematic part. Organizational interventions could be communication techniques, team building, social networking, professional development, things that would be getting people kind of outside that environment. But we know that that's hard to do sometimes when you're working in especially a community pharmacy, when, you know, it's hard to have a staff meeting, let alone a retreat that you get away. So who are you bringing in? So again, those organizational interventions and then the individual focused ones, so it should be a combination of those. And then I've kind of mentioned a little bit, but pharmacy business models tend to be driven by assembly line processes, business metrics that prioritize those metrics over care. So it's not necessarily the right thing to do, but it's easier to track those things, as opposed to, you know, if you may have prevented a patient from being hospitalized for a drug error, that's not something that they're going to necessarily track. They're going to track the ones, how many scripts did you do, or how many injections did you do? And then change the individual pharmacies are likely to be insufficient to address these fully, but there are some individual pharmacies that are doing it. So in Saskatoon, there's one pharmacy that they have all the pharmacists at intake. And so they just sit at a computer, and the patients come in, they bring their script, or they come to pick up their script, they get all their counseling done up front. And then when they're done, once the script's done, then the pharmacist doesn't handle the cash or the transaction at all. It's done by an assistant. And so you may think that that's inefficient, but they've actually found that it's quite efficient, and that they start off a lot of issues because they're able to, if a patient's taking different drugs that maybe they didn't talk about, or an OTC product, it helps them a lot. So there are some models that work, but they're still constrained by the system itself. And then the third kind of main area of this is occupational recovery, so it's the process of what we do when we're recuperating from work-related stress, so on our non-work time, so what do you do outside of the pharmacy or outside of the hospital? It's essential for well-being and preventing burnout and overcoming burnout quicker. The key aspects are psychological detachment, so disconnecting from work and off hours. Some people are better than this. I have a colleague that she's only been with us for 6 years now, but when she first started at 6 o'clock, she doesn't answer her work email. She doesn't do it on weekends. And there's me at 10 at night still answering emails. So I need to be able to detach, but and the relaxation. So what do you do to relax and reduce stress? So or meditation or relaxation can be playing pickleball or something like that too. What hobbies and activities that you have, and then control over leisure time. So the freedom to choose what you do. And so those of us with kids know that sometimes you don't get a freedom to choose what you spend your leisure time on, that you're trucking the kids from activity to activity. But if you, I guess ultimately you're the one who registers them, so you do have that control. You only have yourself to blame, so so that freedom to choose over your leisure time helps a lot too in what you do. Here are just some headlines about pharmacists, burnout, and related things. So NABP has, working to support pharmacists' mental health and well-being and the task force that have been there. Burning out Washington Post, patients are feeling effects. So this is when people start notice, is when patients start being impacted by it. In the UK, they have burnout. They're looking at systematic changes that needs to be done. APHA is doing ones, and they have students working on things to prevent and manage burnout. Looking at it plagues everything from in the school. So are we even training our future pharmacists in the right way by the demands that we have on them? Are we burning them out and saying that it's just part of the process because it's been done in the past? ASHP is doing things as around too, and look at the system supports of it. Iowa Pharmacy Association, this is linked with APHA, and they have some reporting mechanisms, and so we've seen this. I did a report for the Nova Scotia College of Pharmacists, so one of the provinces in Canada, because they want to look at like a whistleblower, but it doesn't seem that anonymous doesn't necessarily work. You have to be able to put your name to things, and so but it seems that APHA is trying to do something, and some provinces in Canada are trying to do this, but they have only instituted within the past year, so we will see if it actually has any power. We did see in Canada some rising up for against PBMs that worked quite well and fought back against those. So there are people can come together. And then here there's quite a bit of resources on the PSW site and looking at worker well-being. So all advocacy organizations are looking at this as well. And then this was an interesting one when I just looked pharmacy burnout and put it in. Is that a new grad this is 2 years ago, but on Reddit was talking about the corporate retail environment and they feel hopeless and that they can't go, they don't have the resources to get out. They don't have enough experience, so who's going to want to hire them outside of retail or a community? I did at one time look at headlines and what people were commenting on news stories about pharmacy and just looking at how many were positive versus negative, and that there's a lot of misunderstanding what pharmacists do in their role in the whole process. And it's easy to blame the person that they made the headline that a pharmacy made an error and a person died by it, but they don't think about the system that led up to that point. And so now we'll move into my studies, and just to provide context, I wanted to show just the most recent scope of practice in Canada for pharmacists. And this is Saskatchewan in particular. So Alberta, the province, has the fullest scope. They've had that since 2007. So it's been 18 years that they've been doing this and quite advanced that, and they're actually clawing back a little bit as far as payment, but it's kind of a model around the world. Where the only thing we can't do right now is scheduled 1 drugs. And then, we have access to lab values, but, they're working on legislation right now to be able to order and interpret those, you know, for INR monitoring and, grants and all those different things that are going on. And so, and most provinces are moving, that way and have been quite successful with it. And on the backs, and the reason why it's moving forward in a lot of these jurisdictions is because there's a shortage of family physicians, and so they need some help. Nurse practitioners are helping in some cases, but pharmacists are the natural ones, so there's an argument that pharmacists could and should be doing more, but as we'll see, that can be catch-22. So this first one is just a paper that we have should have been published a lot longer, but this journal took a year and a half to publish. So, but we wanted to look at burnout in general, and so we looked at exploring the relationship between a workout or not workout, burnout and work engagement in community and hospital pharmacy, and then assess those levels of work engagement and burnout, and then understand if they're completely mutually exclusive or if they're complementary to one each other. So we did an online questionnaire that included the Maslach burnout inventory and then the Utrecht work engagement scale amongst some others. So this was done just as the second wave of the pandemic was kind of starting. And so we included things around pandemic anxiety that went along with that, things like I fear bringing the virus home to work and that type of thing. And also we wanted to look at childcare or caregiving responsibilities of people as well. We got 20%, which seems low, but for a professional, that's good. Majority female, but in Saskatchewan, we're about 72-73% of pharmacists are female, so not that much different. Burnout and anxiety were positively correlated with one another, and there's a negative correlation with burnout. So we did see that effect that they do, you know, if work engagement's high, then burnout, the chances of burnout go much lower. Some implications for this is that reducing burnout improves engagement and organizational performance. So again, if you're looking at strictly as a productivity and financial aspect, then that should be a reason to do it. Differences are that higher burnout among females, those with children or those with caring responsibilities, were had a higher likelihood of that, and then those within chain and grocery stores. And the interesting thing was that hospital pharmacists were the least likely to be burnt out, which I guess in a way we kind of forgot, or at least I did, that you know all the news was around what's going on in hospitals and stuff, but you kind of forgot about community pharmacies. But those were the ones who were splitting up teams and having to do all these measures. And so the strategy should be really focused on reducing that stress and mitigate burnout and enhance engagement. And we looked at all those different ways. Yes, Beth?
If you go back to that slide, that first top one, so is it in that order? To reduce burnout, you have to improve engagement and organizational performance.
Well, that if you reduce burnout by improving engagement.
So it is, that can be the intervention.
Yeah.
Okay.
Yeah.
You don't have to have the reduction in burnout first to improve engagement. If
Yeah.
you can improve engagement, it will reverse burnout.
Yeah.
Okay, just want to make sure.
Yeah. It is the chicken and egg thing.
Okay.
I threw the article in Copilot, and I said, create an image based on this. And so this is the image that it created. And you know, people don't look very happy from this and quite distressed. So it was interesting because usually when you say put something pharmacy in these generators, it's always a community pharmacy setting, it seems. So we should focus on the environment. So employers should create supportive work environments. Again, that's psychological safety. This research indicates that burnout is present but did not give context. So why is it happening? We have a good sense. You kind of assume what's happening, but you don't know for sure. And then future research really look at the different contexts and develop strategies to support pharmacists. This second one was one we just had published in February. No, maybe it was this month. I can't remember. Within the past couple of months, I just put the happy face upside down because I don't want to see a picture of myself. But we did this based on, and so I actually did a preliminary talk on this in Park City last year, and I talked about, the name of my presentation was talking to the suits, because the people with all the power. And so our goal was to characterize burnout from the perspective of community pharmacy leaders. And so those leaders were managers, owners, district managers, and executives of national organizations. And we really want to understand the realities of burnout and identifying effective interventions and ideas that they would have. And so again, in theory, these people have more access to resources and have more say in what goes on in a pharmacy. So naturally that they should be able to make changes. And so we did a purposeless sample. That the purpose sample was that I contacted professional contacts and said, would you be interviewed for this? And all but one person said yes. So I conducted one-on-one semi-structured interviews. And so the interview guide was based and informed by the first study and kind of what we found there. Interviews are 30 to 65 minutes long. We sent the transcripts to these participants and they had to agree with them in order for us to use them and sign off on it. And so we just did a constant comparative analysis and memoing, and then if there was anything that was off, we would have discussion amongst the research team. And so I had a research student with me and then a research assistant that we did this. So the themes that emerged, so there were 6 main themes that emerged, and I'll kind of go through relatively quickly with them because I know the time. But theme 1 is perceived disconnect between frontline staff and decision makers. So remember that these are managers and leaders talking, it's not the frontline pharmacists talking. So they see that there's a lack of awareness and inaction from upper management. So that was sometimes them, but they also talked about the fact that corporate doesn't understand what needs to be done. And so if you're a national chain, what's being done in Saskatchewan is different from Alberta, is different from Ontario, so they don't necessarily understand and appreciate that. So regulators have unrealistic expectations, and this really came out in a lot of the interviews, is that the regulators they're kind of out to lunch, was what a lot of people had said. And government insurers, so misaligned communication and remuneration strategies. And so what they talked a lot about is that so in Canada, yeah, we have a public healthcare system, but each province delivers healthcare, and then with drugs that aren't in hospital, those aren't covered technically. So there is some coverage from the government for low-income individuals and seniors and people with special needs. But for the most part, it's third-party insurance that covers that. So the lack of understanding, communication, problem solving between frontline employees and pharmacy decision makers was the big issue. And so this one quote is that the regulator doesn't understand that it's actually like to practice. So there's that disconnect there between what we can achieve and what they think we need to achieve. So what the regulator thinks is important. Everything they do is because of patient safety, but what if pharmacists quit and being burned out isn't good for patients either. And so I ran up against this with our prevention regulator too, is that, this isn't really, we look at protecting the public, we don't look at advocating for pharmacists, but again, like this quote says, if they're burnt out and they're not providing the care they should be, then it is about patient safety. The second was overwhelming work demands, so staffing shortages, persistent recruitment and retention challenges. And so switching costs from one pharmacy to another for an employee is very simple. Even if someone wants to move between provinces in Canada, with the exception of good old Quebec that is special and has their French language stuff, but all you need to write is jurisprudence, and if you're a licensed a registered pharmacist, another place. So there are people moving around that way, and then the workload is increased clinical and non-clinical, those administrative responsibilities. Participants said current work demands are overwhelming, unsustainable for their staff. And that there's unmanageable professional costs exhausting these employees, and that develops burnout. And when I interviewed these people, this was in 2023, so the pandemic was the WHO declared over before that, and so it was kind of the after effects of it, so. This one quote just said, it seems like people are a lot more burnt out, they keep adding more and more and more onto our plate, we're not getting extra helps ourselves, so. One of these people talked to is that as soon as everything was put on hold when the pandemic happened, and in Saskatchewan, more injections were had to be given and stuff, but as soon as the pandemic was declared over, they said, okay, now back to everything else, so they didn't give them a chance to breathe and recover. There's a cautious optimism toward expanding scope, so concerns are that potential increased burden, so where are we gonna get the time and the energy and resources for this? Opportunities, though, is that there's that enhanced job satisfaction engagement, because you're doing more of what you're trained to do, not the technical aspects. What is gonna be done should be done cautiously and appropriately with adequate resources, so this one said that we have set up teams for success, if not, you're just loading on more work. His expectation is to keep doing what you're doing and then add enhanced scope, it's not going to work. And this is where we're seeing a big disconnect continuing too, is that pharmacists are again saying, oh, we can do more. So in Saskatchewan, where otitis media and pharyngitis are ones that are just new, and so they're saying, oh, look, pharmacists can, well, and as maybe we'll see later, is that, you know, what are you gonna take away, or who are you adding, because you're expecting more but with the same resources. And again, that resource isn't necessarily the right resource. Importance of employee recognition and appreciation. So recognition should come from upper management, professional peers and patients. There's a positive effect on staff morale. Some talked about how during the pandemic, especially the beginning part, you know, well, we didn't get the pans and pots planking like they did in New York and stuff for the nurses and docs, but you know, some organizations were giving hero pay, they called it, because, but then they stopped it. So are you still not here? Like, you're still doing all this work for the organization. And so the employee recognition of staff morale, and it can be protective against it. And so this one spoke about that when you're down and then somebody comes and says, just want to thank you for how you've helped me through this challenge. So that's what makes you keep coming to work, is when those, and it doesn't take much to get something like that. And then the appropriateness and utilization of existing resources, so employee benefits plans, training opportunities. Barriers were the poor awareness and uptake and social stigma around. You know, some talked about the fact that their employees feel that if they go to a counselor or access some type of care, that their employer will know specifically what they did, and that's not the case, but there's that perception like it, so they don't want to do it. So difficulty identifying. So when I asked them any other resources that you think, a lot of them didn't have anything to add besides what was there. They, oh, it should be good enough, but the onus they were placing was on the individual to seek out that. So they weren't doing anything proactively and reaching out and engaging people. They were just saying, oh, this is passively, like, this is what we have available. So more tangible resources like additional staffing would be good too. And then this one quote from an independent banner executive said that don't really want to hear any solutions. They're like, okay, we'll find some more staff and maybe burnout won't be there. So that you, again, that if your solution doesn't involve more staff, then we don't want to hear it. And then the last one is just multimodal systemic responsible and solutions. So there should be some collective action between all stakeholders. And that communication needs to be there, and there needs to be transparency, so not just what told. And a lot of the times, these individuals talked about the fact that how they found out that pharmacists were doing an injection, or there's a new minor ailment that they're prescribing for, was because a patient came in and said, can I get this done now? Or they saw it on the news. It wasn't that they got notification from the government or regulator or anything. It was that people were coming in telling them that you're doing this now. And so this quote just kind of talks about that it has to be all the major players, and that pharmacists themselves can only do so much. They can't make changes. Education also needs to be there for patients so that they understand the role of pharmacists. And that, yes, they are accessible. That doesn't mean that you should be coming to them for everything and expecting fast, prompt service either. So just looking at the current and future demands need to be assessed for their value and reasonableness. Also look at feasible and demonstrate value to frontline staff, and that by that happens by engaging them in what's important to them. And that everyone needs to be there. So personal, organizational, and systemic partners need to be there. It can't be one done in a silo. And then this was the next one, so I threw it in and asked, and so the same guy made an appearance. And he doesn't look as stressed out this one, maybe he's recovered a bit. And so this, we were hoping for more solution-based findings, but it seems that these executives and managers and leaders didn't really have a lot. So they weren't aware of resources themselves out there. So something needs to be done at that level as well. And then a study I did in July and August last year, it was sent out by our provincial advocacy organization. So the previous study was there was managers from Western Canada and leaders, and then ones who were situated in Saskatchewan but worked out of a national office. These ones it went out to frontline community pharmacists, and so our pharmacy association sent it out on my behalf. So I conducted one-on-one interviews on Zoom. The reason is that geography, and you can't always get face to face, and then Zoom likes to transcribe for you. And that's nice, except for some of it's pretty funny what it says, especially with acronyms and such. And so I conducted 14 interviews, and they ranged from 35 to 79 minutes long, and everyone returned their consent forms and transcript release. So preliminary analysis was just completed on Friday. And so not hard, well, it's qualitative, so there's not hard data anyway, but some themes that came out in preliminary discoveries is the burnout culture. So the work environment, increasing demands from both management and patients, and wanting to do more. And then you could also extend that to, governments and insurers are wanting that as well. Spanish school welcomed by some, but many feel unsupported and overwhelmed. So that does jive with what the leaders and managers were saying. The healthcare system pressures and the shortage of family physicians contribute to that workload. And so, and especially in more rural locations, a lot of times the pharmacist is the one consistent healthcare professional. And sometimes it's the only healthcare professional within a geographical area. So there is that pressure on them. And what we're seeing is the government and the regulator that they're starting to do is that they're giving more scope to rural pharmacists and trying to, those are going to be the first places that access is. Lack of support resources, so expected to adapt to new roles without systems and supports in place. And then I include a few quotes here. Just burnout is more common than not. How much more can you get you to do with less money and less staff and less support? They're giving us more and more responsibilities to make them money, but not necessarily the resources to do so in a safe way. Healthcare is becoming more transactional, they felt, the revenue versus care. So that's a moral dilemma that they're faced then, because they're between generating revenue and providing quality healthcare, and that they feel shifting toward the former, that the more is on generating revenue. And I talked to Luke about this yesterday, that, I've been involved in the profession since 2003, and the sky's been falling since 2003. And so, I find that some corporations are talking about like, oh, our margins are so small now, we got to do this, but if they weren't making good money, they wouldn't be keeping open new stores. Public perception, so unrealistic expectations for pharmacists, so when there might be a news release or a media release come out. And they see pharmacists can prescribe, they don't see for what. Or assess for things, they just see that and then go in right away, there's a flood of people coming. And so this one, quote, we're doing way more than ever, yet our framework of our day-to-day workflow has never changed, so it's still about that dispensing model. And we are seeing, so in the province of Nova Scotia, they're doing a lot more of these care clinics. And so that are pharmacist led, and so I met with their director of research for the regulator a few weeks ago. And she said that they're having the good model for assessing the quality and patient reported experience measures and that more transactional looking at dispensing, but they don't know how to fully do it yet in the clinical aspect. Changing patient staff relationships, the reduced capacity for meaningful patient interactions. And so what we saw though is that some older ones felt that the way they were able to start off burnout is that they have those established relationships with their patients. And so that seeing them as a sense of joy and that energizes them, and because they thank and appreciate them. Again, more likely to be in a rural location because as you have an older population in a lot of these areas that it's kind of, you're their social outlet too. And then this one quote, I wish I could find that time where I can have those talks with people. But they don't have, I could have done so much more. I feel like my face is frozen or my lips are sewn shut. Because they realize they could do more and should do more, but they have the baskets and everything stacked up, so they need to also get to all that other stuff, so they just don't ask that question that may have led down a rabbit hole of an issue. Personal health and well-being, so physical and mental health issues and stress from work often spills over into personal life, so affects people's relationships and overall well-being. This one talked about how I had to go on blood pressure meds, I had to get a prescription for Ativan. I'm surprised she didn't say lorazepam, considered the pharmacist, but nothing I've ever needed in my life. It was a version of hell that was a period of burnout. There's culture of sexism in the workplace, and who do I complain to? Who do I go about this? People who are causing the problems. So who do you reach out to when there are these issues? And then safety concerns and risk of errors, so that because of the stress and workload, that increases the chance of errors. And then concerns about quality of care and inadequate training and regulatory standards. And some talked, it's their perception, but a lot talked about internationally trained pharmacists, and not from the States, but we get a lot of people from India is a big one that we get a lot of people coming in from. And so they talked about the standards of their training were quite different, and actually the one who brought up the most was someone who's internationally trained as well, had concerns there. But then this other person said that they talked about environment where they were actually managing and they had to leave, and that it was hard because they don't want to really leave the store they're at, but they have to accept that you're just leaving them behind in a situation that is bad. It feels like you're abandoning both the patients and the people you're working with, and the distress that caused this person is that they needed to eventually, they knew within 2 weeks of working there that it was not a good environment and they weren't getting supports. Yet they stick there for 9 months, and they really, at one point, their spouse just said, you can't anymore, like this is not sustainable and we need you back. And so they quit. And then the need for sustainable work environments. So urge for changes to create more sustainable work environments, mental health resources, and control over their practice more. And retention issues, so the high turnover rates. And so if you're constantly, and that goes with, they talked about not just pharmacists, but technicians. So there's an extreme shortage of technicians as well, the regulated ones. And so there's hard, and then you get these assistants coming in that are trained on the job, but they're rotating through because usually they're paid minimum wage. And then why wouldn't they go somewhere else, like serving, where they could get more money, so, there's a constant revolving door around that. And then this one talk about the refuse to acknowledge that everybody could have a little niche. Most pharmacists feel like we have to do everything and they say that we can do. And that's a lot of pressure. I didn't want to be a doctor, otherwise I would have gone through the training. And so that's some organizations, especially when minor prescribing first came out, said that all our pharmacists do this. Because some organizations weren't making them, but now it's kind of everyone has to catch up, and if our competition's doing it, we have to do it too. And so then that feels like they have to do it, and then there's quotas put on, so medication reviews that they say each pharmacist has to do X number per shift or per week. And there was a big blow up about that in the province of Ontario too, about those quotas and such. So around this was so far just kind of the themes are aligning with the findings of the pharmacy managers and leaders interview. But the frontline pharmacists feel that management leadership can do more and should be doing more. And so I did bring some of what was said into these interviews, and that it was kind of news to these people. So there needs to be more that open communication and transparency needs to be there. And then just the one I just completed in February is that I interviewed 15 frontline hospital pharmacists. We're still reviewing the transcripts, but my initial impressions from doing this, so I did them all, is that there are some differences in relation to burnout, but common themes are being asked to do more with fewer resources. The one thing I was very surprised with was the metrics that were coming. So they call it clinical key performance indicators, not key performance indicators, but and that's taken away from their ability to spend more time with patients. So you're walking through hallways where patients are there and needing help, and they can't do it because they gotta go type up these notes. Lack of understanding by managers and leaders, which is ironic because these managers and leaders are all pharmacists, yet there's a lack of understanding, and that the leaders don't see turnovers only if they leave the health authority or region. It's not about if they leave so if they leave emergency to go to peds because they couldn't handle emergency, they don't see that as turnover and as an issue. So that's maybe something that should be looked at, and that there's no sense of psychological safety there. So there'll be more to come. I want to include this. So my undergraduate, she did directed research studies with me, and she, what's it called, stitched or something, with this sign that says employees must stop crying before returning to work. And actually, because she was present when I was doing the managers and leaders interviews, and a few of them turned to her and said, Stephanie, it's not all doom and gloom. Well, I'm just talking about this aspect of practice. Please don't not go into the profession. But ironically, she went to medicine as soon as she graduated. So, but overall, burnout's a significant issue in pharmacy, which isn't probably a surprise to anyone. It can be lessened through personal, organizational, and systemic efforts, but they need to be coordinated in some way. Those current and future demands require careful assessment for their value and feasibility. And just because someone at head office thinks they're a good idea doesn't mean that it's going to be feasible. And we saw that with this quality improvement initiatives and these, each organization has a different, but Six Sigma or lean initiatives, and that they thought these were great things, but there wasn't buy-in from the frontline people. So I had quite a few people talk about how they'd get people coming from head office, change the dispensary around. As soon as those people left, they changed it right back to where it was. Because it wasn't feasible for them. Work resources have to reflect the realities, and existing resources potential, but they require appropriate application and uptake. So engaging with people and letting them know about the system, and we don't know if you've accessed any resources either, that it's anonymous completely. For this, most of this work, we got a grant from Social Science and Humanity Research Council in Canada. There's my former student, Stephanie, and then Heather was a MSc student at the time, and she was their research assistant. And then, thanks to AIHP and Luke for opportunity to come to Madison and present. And of course, for Beth for taking me for supper.
Thanks for that. We really appreciate it.